Welcome to The Pulse, the official podcast of the Georgia State Medical Association.
Hi, my name is Dr. Keisha Callins. I am an OBGYN and a proud member of the Georgia State Medical Association. But my real claim to fame is that I'm actually was the inaugural speaker actually for the Pulse. And so I'm very excited to be back tonight. And I have a very special guest that I'm going to introduce. Her name is Dr. Kathi Earles. Before I read her bio, I just have to tell you that I did say that I'm an OBGYN, but I grew up for most of my pre-medical school training thinking that I was going to be a pediatrician. I loved kids and was planning on doing that until I actually went to medical school and did my pediatrics rotation, decided that was not for me, and I switched to OB. So no love lost on that. We do have an amazing pediatrician here with us tonight. Her name is Dr. Kathi Earles, and I want to start by just introducing her. I'm going to read her bio, and you will be very impressed. I actually recommend that you look her up online because I'm going to do a short bio, but there's so much more about her that you need to know and that you'll be really impressed with. So, Dr. Kathi Earles is a proud Howard University graduate. She's a physician, an educator, and a nationally recognized leader in obesity medicine. A former executive obesity medical director at Novo Nordisk for 18 years, she has combined her scientific expertise, health equity, advocacy, and compassion care to shape the field of pediatric obesity. She helped establish the pediatrics residency program at Morehouse School of Medicine, which is where I graduated from, and where she also continues to serve as adjunct faculty. She has authored multiple publications, including collaborations with the former U.S. Surgeon General, Dr. David Satcher. Her forthcoming book, Obesity in the Black Community, Weighing the Complexity Above Statistics, reflects her scholarly depth and unwavering commitment to addressing health disparities. So I will tell you that her book is actually out, and it's in my Amazon cart. And we're so excited to have her here tonight to be a part of our conversation. We want to welcome you back to our show tonight. We hope that you'll have a wonderful time. And we're looking forward to hearing from Dr. Kathi Earles. So, Dr. Earles, would you like to just introduce yourself briefly and tell us a fun fact about you?
Let me see, a fun fact. Hi, I am Dr. Kathi Earles. Dr. Kathi, a fun fact. I'm an avid WNBA fan, and I've gone to the Atlanta Dream games, and I feel like I'm on the team. And they lost the other night, so if I seem a little melancholy, you'll understand why.
Fantastic. Well, now we know how to get your attention. We can talk about basketball,
yes,
women's basketball.
Yes.
So wonderful. So I have a couple of questions just to guide our conversation tonight, and I want you to be totally honest with us.
Sure.
So the first thing is, a lot of patients will say, "Why am I hungry all the time?" Can you help us understand why that is a common phrase that people express when it comes to how they're thinking about their desire to eat?
Yeah, that's a great question. Oftentimes, we think of the fact that either we're hungry or that we're full. We think that it just has to do with us. And there's this misconception that it is a fault in us when we eat too much because we're still hungry. But what we know now, based upon the science that I really don't think was apparent back when I was a medical student, is that there are certain hormones that are responsible for us to be hungry. And then another hormone responsible for us to be full. And there's only one of those that we know about. So what happens is that when we're hungry, certain hormones that are being released. And the big one that we know about is ghrelin. And I mentioned ghrelin because it is actually produced in the upper part of the stomach. And the reason that's important is because one of the surgeries that is a weight loss surgery removes that portion. So the hormone that causes us to be hungry is immediately, largely eliminated. Although it is produced in other parts of our body, the main part is eliminated. So your hunger, and it goes away right away. So anyways, without that, you have this ghrelin being released, and that ghrelin has the ability to send these messages to your brain. And there's a portion of your brain that when it is stimulated or when it is touched or when it is aggravated, you become full or you become hungry. And so the ghrelin stimulates the site that causes you to be hungry. And at the same time, it stops the site that causes you to be full. So that's what happens and makes you hungry. So then also at a certain point throughout your body, or throughout your intestinal tract, you have other hormones, which when they're released, they cause you to be full. And so they kind of do the opposite effect. They travel on and send a message to an area in your brain, which stimulates an area to cause you to feel full. And at the same time, it cuts off or stops the site in your brain, which causes you to be hungry. So they work in opposition to each other. So you have one hormone that causes you to be hungry, ghrelin, and then you have several others that cause you to be full. And so that's essentially how it works. Now, I say that, but I also like to give you a caveat. There can be multiple areas of abnormality in this whole system. Because if you think about it, some of us get hungrier than others. Some of us get fuller quickly. Some of us have a real hard time getting full and therefore eat more. And we used to think that was all our fault. We blamed it on ourselves. But now we know that there's actually a science behind it, and there can be abnormalities in that science that cause us to eat more, be less full.
So is there a way that we can trick our bodies? Like if we drink more liquids, can we get the feeling of being full and turn that off? I feel like there's a switch that we can flip somewhere, like maybe behind the ear or something that we can just turn it off. Is that something you can do? How do you, how can we circumvent that pathway?
That would be very convenient. One thing that you mentioned is a fullness. Okay, so there's that stretch, okay, in your intestinal system or in your stomach. And what happens is because of that stretch, again, there's a message that's sent to the brain to tell you your stomach is stretched, everything is stretched, and you're full. And on the same time, it stops that area in the brain or tells it to cut off that causes you to be hungry. So what you're talking about is like if I drink like a gallon of water before I eat, will I eat less? Probably, and I say probably so. But again, everyone's body is different, and there can be malfunctions in that entire system that make some of us eat more, and some of us eat more because we feel less full. And there's also a genetic component and all kind of things. One of the, I'd say, negative historical issues that has occurred is that when I was in medical school, we didn't learn that it was a science. The science may have been developed, but we didn't learn it. And so we were brought up with this assumption that it's essentially the individual's fault for having an increased weight, that it is their fault for not being able to stop eating. And now we know that's not the case. However, the issue is that many of us still didn't learn it, right? That's one thing. The other thing is that it's not as prevalent in medical school education even today as it, in my opinion, as it needs to be. So
thank you for that. And so just to center the conversation, I wanted to share with the audience, I don't know that I said the title initially, but tonight we're really actually focusing on childhood obesity and health equity and also community power. And so we're going to talk about a lot of things. And the reason we have community involved in this conversation is because when we think about especially childhood obesity, we know that the kids have parents and caregivers. And so this conversation is not just directed to the child, it really is to the family and to the community as well. So I've got one more question about the fullness concept, because I'm really enamored by that, Dr. Earles. So I have a lot of patients, I'm OBGYN, and I have a lot of patients where I'll say, are you feeding your feelings? Where when you feel a certain way, you tend to want to eat certain things. And how does that play into our decision to eat and kind of how we not train our body, but how we respond to how we're feeling? Could you talk about that a little bit?
Sure. So just to, there's certain areas in the brain that when they're stimulated, they release a certain hormones that cause you to feel a certain way. So we actually have an area in our brain which some food can cause that hormone to be released, which really causes us to simply want the food more, right? And it's very difficult to turn it off because it's reinforced by those hormones, which cause you to want to do it again. I give you an example. But then there's another area that really is just responsive to hunger and fullness. Okay. So, but if you have something that stimulates that area that causes you to want to do it again, you don't even have to be hungry. My example for this is I don't know if I can mention the store, but they have this carrot cake, right? I can be full as ever. However, eating that carrot bundt cake stimulates the site in my brain, which causes hormones to be released to make me feel good. And I want to feel good again. So what do? Have another piece of carrot cake, you see? So depending upon the various areas in your brain which are stimulated based upon the food and so forth, and also based upon your own genetic makeup, can determine quite significantly what you eat, what you don't eat, when you stop, and when you continue.
Thank you for that. That's a good conversation. I have a lot of thoughts, and I actually really do like carrot cake, so we'll have to talk about that offline some more.
Yeah, for sure.
So since we're talking about childhood obesity, I want you to talk a little bit about BMI. What is BMI exactly? What is it a measure of? And is it something that really we can use for children as well as adults? And does it work across, regardless of what your demographics are or where you may come from? Would you speak to that a little bit? Because that sometimes I think is a little interesting for us to understand how we're being compared, so to speak.
Okay. All right. So BMI stands for body mass index, and it is your weight in kilograms divided by meters squared. In other words, the way I like to think about it, it's essentially how round you are or how round you are or not. It's the weight divided by your height squared. Make sense? Okay.
Yes.
So BMI has been used to quantify whether an individual is above what is expected and what is perceived as being unhealthy, or at the appropriate weight or below. Now, the problem with BMI or body mass index is that it was built upon the heights and the weights of Caucasian people, right? Without African Americans in that population. And there are differences between us from a body composition status. I'll give you a point. So, for example, if you look at your weight, okay, depending upon your shape, you could have a pear shape or you could have an apple shape, right? The pear shape is actually more healthy because that weight around our hips, that tissue there is not as toxic as that's around our abdominal area. But you could have the same weight as the apple shape. And so what has happened is that if you have the same BMI of that apple shape and you're a pear shape, you're actually healthier as that pear shape than you are as the apple shape. The other thing, does that make sense?
It does.
Okay. The other thing is there was this really great article by it's a Dr. Fatima Cody Stanford, and what she says is that at the same way, if you have a white patient versus a black patient, the cardiometabolic risk, in other words, all the risks that are associated with having that elevated weight are different for Black patients versus white patients, meaning that you cannot compare the two because they're different, and that you should have you should consider that when you're looking at the body mass index of the individual. You need to consider their ethnicity when you're talking about how much at risk they are. And you should also consider things like their waist circumference, their waist to hip ratio, because that'll determine what kind of shape they are, which we talked about the apple versus the pear.
That's very good. That's a good description. Thank you for the visuals. And so let's delve a little bit more into the whole childhood obesity. We know that there's a lot of information about that becoming a public health emergency or even an epidemic.
Mm-hmm.
And I'm wondering what your thoughts are on, how we help our families to address the lifestyle. I'm not going to say diet, the lifestyle changes that we really need to be doing to help our children.
Sure.
Where do we start with that?
Well, one thing, I think acceptance is one thing, but then I also like to say, when we just talked about, how BMI is not exactly equal across ethnicities, neither is that growth chart. Okay, so that's the first thing we want to look at. The growth chart was actually developed 1964 to 1994. Right? And it contained only Caucasian children, not Black or brown children. So we want to consider that, because there is a difference in the rate of growth in different ethnicities. That's one thing. The other thing is that when we are talking about a child, right? So it's supposed that growth chart is supposed to be used as a tool, not as a definitive tool, but to give you an idea, okay? And it's important to look at the growth trajectory. So not just one point in time, but several points over a period of time. Now, the other thing too is that when we're talking about it, I have rarely seen a child who is, even after you consider the ethnic differences that may occur, a child who is above the average age, significantly above the average age at multiple points on that growth chart, in which the parent also, or the family members, or the caretakers also are not above average on that curve. So I mention that because I've been in rooms where there will be a focus on the child, right? But we need to talk about the whole family, because typically children are not the ones who make the rules, buy the groceries, cook the food.
Correct. Yeah. So I want to know then, how do we promote approach to being healthy? Like, what does that conversation look like if you do have, I have patients who come in that are 15 and they weigh twice what I weigh. Yeah. So how do you start that conversation in a way that is empowering, but also really focusing on health? What does that sound like if you're talking to grandma that may be there with that child?
Mm-hmm. Okay, so that's a great question. One thing, I'm not trying to beat up on healthcare providers. However, what we have found based upon the research is that some of us as healthcare providers are some of the worst ones, right? In terms of the bias and stigma that we portray, or that's associated with patients who in fact may come in overweight. There was a study that was done that looked at providers and asked them how long they would spend with patients that had an elevated body mass index or were overweight, right? And what they found out, based upon their own answers, was that these providers will spend less time with a patient who was overweight or qualified for having the disease of obesity. They were less likely to sit down in the room. They were less likely to look them in the eyes, and they were less likely to have them follow up or even make the diagnosis. So that's on us. Okay. And then what they found out too was that once these patients left the office, if they received that type of treatment, they were more likely to not return. They were more likely to become depressed, and they were more likely to eat more. So instead of, the doing no harm, we actually have done harm, right? Okay, so that's number one. What was the other part of that question? I'm sorry.
Just how do we have that conversation to empower?
Yeah.
Like,
Okay.
what does that sound
Yeah.
like?
So the other thing is, so the other thing too is, Dr. Callins, I don't know about you, but when I was in medical school, we didn't learn the whole motivational interviewing thing, right? So we learned, okay, this is what you do, A, B, C, D, but we know that's not beneficial and it doesn't work. So kudos to the medical students right now who are learning the motivational interviewing, where you sit down and you ask the patient, what do you think we can do? What are 1 to 2 steps that you think will be doable between now and the next time we see each other? And that could be something as small as drinking, instead of no water, let's start with 2 glasses of water a day. It can be something as small as, instead of not doing anything in terms of physical activity, to taking 1 flight of steps instead of the elevator all the time. It can be something as easy as walking a block one day, and then perhaps 4 weeks from now, you start walking 2 blocks. But the important point is starting somewhere, validating them when they come in, because that's a big deal, and then increasing that, right? So empowering them to make choices in terms of activity, but also with eating. Fast food is a big culprit. Eating in front of the television is also something that we could curtail or do less of. What we know is that when we eat in front of the television, we eat more than when we don't. When we eat as a family, we eat better and healthier than when we don't. When we eat earlier, as opposed to late night eating and late night snacking, there are less calories associated with eating earlier than eating later. There are also things like sleep. Sleep is a big deal. What we know is that there's this pattern of these hormones, which cause us to be hungry again and cause us to be full. And we really kind of mix them up when we don't get enough sleep. So sleep is a really big and important part of it. So there are multiple areas that we can address when we see our patients. But what I would suggest is that we start somewhere. Ask them, what can we do? What can we agree upon right here? What can you agree upon? Because what we know is that when we tell someone what to do, it's better if we're able to make the decision together. And if we agree upon it, and then when you come back, then we can build upon that. Baby steps. Because what we wanted to do, Dr. Callins, is we want the changes that are made, the healthy changes that are made, to be persistent,
long lasting.
Yes, exactly.
Yeah.
Exactly.
Well, I'm really happy that you mentioned those thoughts. I had a couple of thoughts. Number one, the ads on TV. If you watch TV, all these sandwiches and chicken and burgers, and even if you're not thinking you're going to eat it, you keep seeing the food all the time. I think that might be activating something in our brain.
Oh yeah, for sure. Suddenly you want it. Hadn't thought about it all day.
And so that's a culprit. The other thing I was going to share is that, when my daughter was in elementary school, her coach used to tell all of us, the parents, if you're watching TV, when the commercials come on, do 5 push-ups, do 5 sit-ups. And what happens, if you think about it, if we do small things frequently, we also develop a lifestyle. And so you probably could kind of eat what you wanted if you did 5 push-ups and 10 sit-ups for every 10 minutes, right? When the ad comes on TV. And so I think really talking to patients about how to meet them where they are. I love that you said that. What can you do? How can we be a partner together in your care plan? And I do think that it takes time to do that. That can't happen in a 5-minute visit, right? I mean, you have to allow time to be able to make that impact. And so I do think as providers, we're responsible for, maybe every visit doesn't have to be a long visit, but I do think we have to invest in figuring out where people are. And I spend a lot of times, I usually ask patients, well, what did you have for dinner? And they always are surprised. And I said, I need the whole truth, nothing but the truth. And they said, okay, Dr. Callins. But I think we do have to get that specific. The last thing I'll mention is that motivation. So at one point, I used to pay patients $1 for each pound they lost. And I will tell you, I would go to the bank and get a lot of dollar bills, and it did look a little interesting. But I had people losing 5 pounds at a time, 3 pounds. And that motivation that you talked about
Yes.
really goes a long way.
Yes, for sure, for sure. You mentioned one thing that stuck out to me. That was great. You mentioned children's television. Right. So they did a study. If you look at children's television versus television that is for adults, children's television has many more commercials on fast food, candy, all of that. So it's targeting. I mean, it's by design for the children versus that we see. The other thing too, you mentioned, food. It's almost easier in some respects to go to the drive-through. But how many of those drive-throughs are healthy?
Yeah,
And
it's challenging because I
yeah,
think it also depends on time. I think what happens to a
sure.
lot of families now, they're doing a lot of sports in the evening,
Mm-hmm.
baseball practices every night, then you got to do homework. And so it becomes convenience, but not out of malice per se or
Mm-hmm.
intention to
Sure.
be harmful, but it's easy. So what I do with patients, I tell them all the time, when you go, if you do have to roll through a fast food, order from the kids menu, right? We can do
Mm-hmm.
portion control.
Yes.
So if that is your only choice at that time,
Yes.
not getting, the 5 for 4, the 4 for 5, or
Right.
all of that
Yeah.
can make a difference in terms of the calorie intake. And I think
Yeah.
that's, helping people to make choices with what they have is also helpful.
Absolutely. Absolutely. So you mentioned one thing that stuck out to me about going through the drive-through, right? If you're doing, a lot of activities and you come in and you're working and perhaps you didn't cook for that day and you had to pick your child up from practice, this, that, and the other. That's one situation. But then there's also the situation where all you have is fast food in your neighborhood, right? You have every fast food option, every wing shop, every corner store. But in terms of access to, we often talk about fresh fruits and vegetables. I'm going to say even frozen vegetables, access is very limited. And so your choices become extremely small, such that going through a fast food drive-through, having that option sometimes becomes the only option. And we're talking about, we always hear the social determinants of health,
Mm-hmm.
lack of fresh foods and vegetables. I tell a lot of times my patients, get the frozen vegetables. That's what we have, right? Lack of areas. You mentioned, picking your child up from volleyball or from soccer or for whatever the case may be. In many of these neighborhoods, there are no parks. There are no outdoor activities. There's a lot of concrete. There's not a lot of areas outside where you have trees overhanging such that it blocks some of the sunlight. Those areas are actually hotter, right? So it's one thing to have the opportunity, to have the option to make those changes, okay, easily. But then there's another situation when it becomes very difficult for you to even buy healthy food, for you to even buy exercise in a healthy and a safe manner. And we talk about things like adverse childhood events, right? Hearing gunshots. Okay? We know that that's associated with an elevated weight, just the stress of that, being able to sleep, all sorts of things that make it extremely challenging to make the necessary adjustments to live a healthier lifestyle.
Yeah. So I want to talk about two more things. Number one, we hear a lot about food insecurity. There is a big conversation about kids having access to food. My daughter and I volunteer with Backpack Buddies, where we make backpacks of food for kids to take home for the weekend. And we know that if the brains are not fed, then that can impact their learning. So can you talk to us just a little bit about how our nutritional intake also is a factor of not just the weight, but also our ability to learn and to be able to progress as well?
Yes. So our nutritional, and so not just, like what we eat, right, but how healthy what we eat is. A long time ago, there was a study that looked at kids who ate breakfast versus those who don't. Right? And they found that kids who eat breakfast are more alert, they're more in tune, and it seems like do better in school than those who come in hungry. It almost seems like we had to do a study to find that out, but we had to, right? So now we know too that there's also a difference between what you eat for breakfast. So if you eat the something from the corner store, which is typically going to be something sweet and high in fat content, that's a little different than having some fruit and maybe a scrambled egg and piece of bacon eat. You know, there's a difference there. So certain things like eating breakfast is a big thing. Eating lunch, drinking enough water. And the other thing too, Dr. Callins, is it depends upon, we talk about school, it depends upon where you are in school. What kind of school are you in? You know, if you are in a public school on certain sections of town, your breakfast or your lunch may be considerably different than if you're in a public school in another section of town.
Yeah, that's good. And so with that, I also want to talk a little bit about a culture of how we reward ourselves with food, right? You think about graduations, birthday celebrations, and when I counsel patients about elevated cholesterol, I say, well, you can only have, your favorite thing on your birthday, not everybody else's birthday. So speak to us a little bit about how we shift to not having food as a reward. I had a patient who was losing weight, and then she started gaining, and she got a boyfriend who was buying her cases of honey buns. And I said, tell him you want flowers or jewelry, no honey buns. Right. So we have to reset our expectations for rewards. So talk to us a little bit about that reward system, and as a culture, how we celebrate things and what food means for that process.
Oh, yeah, we do that all the time. And I would say that from a cultural perspective, perhaps we can incorporate food as a reward, but I would like to say it's what food we incorporate.
Carrots.
Yeah, well, I mean, you can make a
not
carrot
cake.
taste good. Yeah, maybe not cake, right? Or maybe the cake is not there all day, or maybe the cake comes out as pieces so that you can't continue to, make a larger piece if you want. Or maybe it's a different kind of cake, or maybe it's fruit instead of cake. But there are adjustments that we can make such that we don't abolish things that we have done from a cultural perspective the majority of our lives and still be healthy all at the same time. I think it takes a really conscious effort to do so. And it takes perhaps multiple conversations on our part as healthcare providers to actually encourage that. And I think one thing that I think you touched on a while ago is to talk about our struggle. We've all been through it, right? We just talked about the carrot cake.
Right. We connect on that.
We can, definitely like sisters. But there is something that you can do. You can make certain changes to the celebration. When I was growing up, we never had Halloween candy. We didn't know because my mother would take the bags when we got home and she'd substitute other stuff. So we didn't know, right? Now, that was a bit extreme, but there are things that we can do such that what we typically see as pleasurable or what we typically see as the routine, we can kind of alter them such that it doesn't make it less pleasant, but it makes it pleasant and healthier. Does that make sense?
Well, I'm guilty. Yeah. I'm guilty. I used to hide the Halloween candy from my kids, and I would give it away, which didn't make it any better because I gave it to somebody else. But I am guilty. So real quick, I wanted to just share with the audience that both you and I are participating in the Climate and Health Equity Fellowship. That's part of the Medical Society Consortium of Climate and Health, and also the National Medical Association. And so I want to give you just a couple of minutes to talk about how climate change impacts obesity, and in particular childhood obesity.
Okay.
I want to share that with our audience because I think that's something that connection may not be someone that comes ready to mind easily.
Yeah.
And so will you share on that?
Sure. So it's not just for children, but it's for adults too. And I have to tell you, Dr. Callins, before we got involved in that fellowship program, I was clueless on the whole thing, right? But what we know is that in areas, particularly in what we consider to be, what we call marginalized communities, in areas that, from a historical perspective, you may have a lot of low-income housing, you may have less grassy areas, you may have more concrete, less trees, and you may be built near a freeway. So what we know is that the climate, the earth is warming. Okay, we know that, and we know because of that, certain chemicals which used to be released and were able to be released are now not able to be released. And many of these chemicals that used to be released are toxic. So it's causing us to be unhealthy. However, all areas are not impacted equally. Those areas where you have these communities, where they built these public housing, for example, where they don't have a park, where they are unsafe, where they are living in areas where they hear gunshots, which we've already talked about, that are built right next to the freeway, they're actually hotter and warmer than other areas which may be on other parts of town. And so that not only increases things like obesity, but it also increases stress. It also increases disease. It also increases the prevalence of asthma in our kids. And we already know that Black boys have some of the highest prevalence of asthma that there is. So to live in that kind of environment only increases it. And when we talk about, climate health, many of these environmental regulations have been rolled back. And when we look at a lot of the majority of, I don't want to say the majority, but quite a few of the areas that have been impacted are low income, Black and brown areas where we have toxic waste being dumped. There's what's that in Louisiana? There's an entire stretch where toxic waste exists, and the individuals there have a significant amount of health abnormalities than other folks living on the other side of town, right? And yes, go ahead.
No, I was going to say that's good, because I think what you're sharing is, as clinicians, physicians, we have a responsibility to help our patients become aware and to help them advocate for the changes in the community to help protect themselves. And
Absolutely.
we can raise that awareness. Do you know what's close to your house? And I think, as physicians taking care of vulnerable populations, we have a responsibility to say, have you thought about this, or your environment could be making you sick? And so I'm really glad that you brought that up, because I think we don't think about that all the time.
I think I would like to say too, because we're, I don't want to say aware, but becoming aware, more aware, we also have the responsibility to speak out about it and to become advocates for this. And I mentioned that because before I got into the fellowship, I really didn't understand the gravity, the magnitude of the problem. But now that I do, it's kind of like you can't know about it and then do nothing. You have to speak out, get on boards, meet with your politicians, everybody, speak out about it in every venue that is possible. Yeah.
And I believe I'm going to quote you correctly by saying that we have to be on one accord, right? And on key, right?
Yes.
Those are the words.
Yes.
As we raise our voices so that it's impactful.
Absolutely.
That's a great quote. So as we start to wrap up, I really just want to congratulate you and highlight you for your recent book publication. It's one thing to have 18 years of experience and to live the work and take care of patients, but you have taken it up a couple of notches and you have authored a book. So why don't you just tell us a little bit about that book and why that's important for your contribution to our community?
Okay, so the book is called Obesity in the Black Community, Weighing the Complexity Above Statistics. And let me also say too, I am not the only author. Publication company reached out to me about composing the book and knowing that I needed some help, I reached out to a couple of sisters who are physicians who are younger and have a lot of energy and are well authored in this space, and asked them to be the second and third article author with me. And then after that, when we developed the table of contents, we reached out to some other experts in the field of color to participate. And so we have a variety of different views, but all really speaking the same core in terms of the science and in terms of what things can be done to mitigate the situation. And so the book goes through obesity in the pediatric space. It also talks about obesity from a cultural perspective. It talks about things from a historical perspective, in that the freeway built next to the low-income housing didn't just happen. Right? The fact that there are a significantly decreased or lower percentage of Black and brown families that own homes did not just happen. The fact that the VA money from the VA bill was only given to a very, very small percentage of Black soldiers who fought in the war, that didn't just happen. So when we talk about it, so that's all in the book, because oftentimes we say, well, just pull yourself up off your bootstraps. You got to have bootstraps to begin with, or access to them. And
Amen.
the reason that we don't, it didn't just, it's not because we're less than. So we need to stop beating ourselves up and do what we got to do, right? Yeah. The other thing is, so the book goes through the comorbidities or the diseases that are associated with the disease of obesity. And it's just each day, it's like we're finding out a different one. There's several different types of cancers. There's orthopedic abnormalities that are associated with increased weight, prenatal issues that are associated with increased weight. We already mentioned asthma, but there's a whole assortment of things that are associated with having an elevated weight. Whereas if we were able to develop a healthier diet and a healthier lifestyle and perhaps decrease some of that, then we would be overall healthier. The other thing too is that the book kind of does away with the myth that it's the individual's fault. It explains the science of it, so we can take away the guilt that many of our patients feel, that it is not their fault and that we can in fact do something about it. And I think we mentioned this earlier, baby steps, so that it's able to maintain.
Thank you. Dr. Earles, you've been fantastic. I really just enjoyed your candid education regarding a very sensitive issue. And I'm hoping that our audience will really take to heart the things that you've said. And at the very least, even though we know that the BMI and there are other things that are not really designed to evaluate us, we want to think about what our call to action is. And so I'm going to give you a chance to share that. And while you're thinking about your call to action for the audience, I'm going to wrap up with a quote from one of Whitney Houston's songs. I believe the children of the future, teach them well and let them lead the way. And I think as adults, we have a responsibility when it comes to lifestyle and health and diet and food and nutrition. We need to teach them well and let them lead the way. So with that, I'm going to give you the last word as we wrap up this episode of The Pulse, and tell us, what is your call to action? I want your call to action for parents, for physicians, and for the kids who are listening.
Okay. All right. So let me start with the physicians. Okay. I think it's really important for us to kind of analyze the language that we use when we talk to our patients who have the disease of obesity. We have to begin with avoiding blame and avoiding shame, because what we know is that not only does that not help, but it does harm, right? And that's causing or adding, what do we say, wood to the fire. Okay, it's making the problem worse. The other thing too is I think it's important to screen our patients early. Oftentimes I think we wait until they're tipping over, but if what we want to do is notice the trajectory before they actually get to the point in which their health is very, very significantly impacted. So prevention is more effective. The other thing too about prevention is it's okay to really talk about a healthy diet and a healthy lifestyle with a patient who comes in who has a normal weight. I think it's important because when we talk about health, it's not just having a normal weight, but it's healthy activity and a healthy diet as well. Exercise, sleep, that whole kind of thing, stress regulation and so forth. So it would be great to talk about it before it actually happens. The other thing too is to have the conversation about barriers in our patients for our families, for our children. So ask our patients, do you have access to grocery stores, right? Not just one grocery store, but grocery stores. It's not just about calories, but it's about the type of food that's in those grocery stores. And I will tell you, Dr. Callins, for quite a period of time when I was seeing patients on a regular basis, I would always tell them, I need you to go to the grocery store. And I would kind of preach it, I'm sad to say, until I went to visit that grocery store. And what I noticed about that grocery store is that the fruits and the vegetables in there were not going to last a long time. So when I would tell my patients, go get fruits and vegetables to last a couple of weeks, they weren't going to. So then I'd have to switch things. Perhaps we talk about frozen vegetables and fruits, but I only knew that because I went to visit the grocery store, and that was after several years of preaching about it, right? I had to learn, but it's important to take small steps. So not just look at things like we mentioned food, but what kind of medications are our patients taking? Because there are several medications that are associated with weight gain. What kind of stress are our patients experiencing? Is mental health an issue? Do we need to try some behavior modification? What kind of activities are they participating in? When we tell our patients, I need you to increase your activity level, what type of area do they live in? What type of neighborhood do they live in? Do we have to kind of change the activity that we're recommending based upon where they live, right? So to consider those facts and to treat or see every patient individually with compassion, with that motivational interviewing that perhaps we didn't get trained on, but we know it's impactful for our patients. So the other thing too is to advocate. One thing I've learned participating in this fellowship is that a lot of the politicians' doors are more open than I considered them to be, right? But to become a voice, since we know, become a voice of education for healthy eating, healthy activity, to bring awareness to the disease of obesity, to bring awareness of the disparity in our various communities, but to advocate for our patients and our families.
And I think those closing words would speak to what the caregivers and parents need to do in the community, is to advocate for the changes, to have access to the fresh fruits and vegetables. I work in Twiggs County, and then the next county over, Wilkinson, they just lost their grocery store. They have a school there. And so I'm listening to you talk about this and I'm thinking, well, where are they eating? Yeah. And so, so I do appreciate that. Well, I want to wrap up this session and just, you are my friend, fellow physician and colleague, fellow in the chef program, but it truly has been an honor and a privilege to speak with you. And thank you for speaking from the heart and really calling to action what we need to do as physicians, but also as a community to really tackle a problem that is really impacting our children now and also their future life. And so thank you for being a guest tonight.
It's my pleasure. My pleasure. Thank you.
Right. Thank you.
The content shared on this podcast is for informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. The views expressed by our guest and host are their own and do not necessarily reflect the official positions of GSMA. At GSMA, we stand on over 130 years of medical excellence and advocacy, but we encourage you to always consult your physician or qualified health provider with any questions you may have regarding a medical condition. If you think you may have a medical emergency, call your doctor or 911 immediately. Until next time, stay informed, stay empowered, and stay well.